So good morning, everyone. It's my entire pleasure to introduce Cynthia de Carvalho Fischer. She's a second-year resident in our department and will give a talk on GIST this morning. So Cynthia, please.
Good morning. The subject of today's resident lecture is gastrointestinal stromal tumors, or GIST for short. What are GISTs? GISTs occur throughout the entire gastrointestinal system. They are the most common mesenchymal or stromal neoplasm, and they mostly overexpress the KIT receptor, as seen in this histological slide below. This is a picture of a massive GIST removed surgically by our team. Let's start with the molecular pathology. What is the KIT receptor? I mentioned earlier the KIT receptor is a transmembrane receptor, a tyrosine kinase enzyme. Approximately 80% of GISTs have mutations in the KIT receptor gene that lead to a constant activation of the KIT receptor. Mutations can occur in multiple exons of the KIT receptor gene, and they mostly lead to a ligand-independent activation. What does this mean? This means that the stem cell factor that would normally be required to activate the receptor and to activate these pathways of survival and proliferation, that stem cell factor is no longer needed and the receptor functions merely on its own. The most common mutation in GISTs is exon 11. Why is this important? This is an ATP binding pocket in the intracellular portion of the receptor where tyrosine kinase inhibitors such as imatinib and sunitinib bind and stop the process. A little more molecular pathology. So as I said, 80% of cases will have a mutation in the KIT receptor. However, in 4 to 5%, the GISTs are immunohistochemically negative for KIT receptor. How does this happen? Some may have mutations in other Z genes, such as the platelet-derived growth factor receptor alpha. Interestingly enough, these GISTs are often also sensitive to tyrosine kinase inhibitors. And sometimes what happens is that there is transcriptional silencing of the KIT receptor protein via another mechanism. So in 15% of cases, GISTs lack a mutation in the KIT receptor gene at all. These are wild-type tumors and are often not responsive to tyrosine kinase inhibitors. The hypothesis is that GISTs originate from interstitial cells of Kayal. These are the cells that regulate peristalsis in the GI tract, and they sit between the smooth muscle cells in the muscular layer of the GI tract. So I'd like to play a little game of who wants to be a millionaire at this stage. Maybe everyone can imagine the dramatic music. First question going for 50 francs. What is the incidence of GIST? Who can help me out? And someone help me out with this one?
B?
B? That is actually correct. Well done. That is an incidence of 0.68 per 100,000. So what does that mean? GISTs are rare. Moving on to the second question, maybe more money will motivate us. So this one goes for 100 francs. Where are GISTs more commonly located?
A.
It's A. I see the motivation already. Okay, it is the stomach. So again, most GISTs will be located in the stomach, but a close second are GISTs located in the jejunum and ileum. 5 to 15% of cases occur either in the duodenum or in the large intestine, and GISTs of the esophagus are rare, and even more rare are extra-intestinal GISTs. Third question, 250 francs. Where do GISTs commonly metastasize to?
B and C.
Okay, ooh, this is gonna be a hard one. Do we go back to 50 francs or do we move on? It's C, it's liver and peritoneum. GISTs rarely metastasize to lymph nodes and lungs. And this is our last question, and we all want to be in a good mood today, so this one going for 1 million francs. What symptoms do patients with GISTs commonly present with?
I think it's E, all of the above.
That is correct. That is absolutely correct. We have all won 1 million fictional francs. So it's important to note that most patients will present with unspecific symptoms. And however, 50% of cases with gastric cysts will have some form of GI bleeding, whether it is occult or overt. 20% of patients will be asymptomatic. Cysts are an incidental finding in these cases. So in our endoscopy, our cyst may present as a submucosal tumor with smooth margins and a central ulceration. This is called a belly button appearance. In the ultrasound, we might see a submucosal hypoechogenic and homogeneous mass that comes from the muscularis propria layer. Features of a high-grade cyst include calcification, cystic spaces, heterogeneous patterns of some sort, and irregular borders. So now that we have seen this belly button, the question is, do we biopsy it or do we not biopsy it? A biopsy would help us confirm the diagnosis and plan therapy. However, it also has risks such as perforation or the risk of tumor dissemination. The European Society for Medical Oncology has recommendations on this subject, so all nodules under 2 centimeters should not be biopsied or excised. They have unclear clinical significance and they recommend surveillance. A surgical excision is only recommended if the tumor increases in size or becomes symptomatic. For nodules above 2 centimeters, they should be removed surgically. However, if we suspect metastatic disease or advanced disease, we should biopsy. The imaging modality of choice is really the CT scan. Here in the CT scan, we can see a mass in the stomach that enhances with IV contrast and that has like this central hypodensity, which is probably due to either necrosis or a hemorrhage. An MRI can be used for specific sites, such as the rectum, to assess infiltration. A PET scan is really a supportive modality in this case. It isn't it's less specific than a CT scan for diagnosis and even for assessing response to tyrosine kinase inhibitors, for example. However, it can be useful in identifying metastases and showing us what's tumor and what isn't, and also as a supportive imaging for assessing response. So again, CT is to be preferred over a PET scan. So in principle, all cysts have the potential to be malignant, meaning the potential to recur, to metastasize, or to grow expansively. However, it's important, obviously, for our patients to identify which ones that had a higher risk of doing so. So Mitienen et al. And then also the College of American Pathologists looked at tumors at 2,000 patients and correlated the characteristics they found in the pathological specimens with their outcomes. And they found that there are a couple of features that suggest a less favorable prognosis. So if the tumor cells have a higher mitotic rate, if the tumor is large, and also they found that small bowel cysts are more likely to have a less favorable prognosis than gastric cysts. Later, other elements were also identified that suggest a less favorable outcome. So mutation status, whether the tumor ruptured intraoperatively, and certain CT scan characteristics have also been correlated with outcomes. This is a nice table that based on these characteristics we just talked about, separates cysts into several categories. Very low risk cysts are those that are under 2 centimeters and have a low mitotic rate. And then as the size increases and as the mitosis rate increases above 5, the risk becomes higher. This is particularly true for non-gastric cysts. So let's talk about the basics of managing cysts. Surgery is our first-line treatment for those cysts that are localized or potentially resectable. Intraoperatively, there are a couple of elements that we need to remember. These cysts are often fragile. We have to avoid rupture intraoperatively. We should try and resect GISTs with an intact pseudocapsule, and if possible, a safety margin of 1 to 2 centimeters is recommended. A lymphadenectomy is not required as a standard because GISTs tend not to metastasize into the lymph nodes. GISTs show poor response to classical conventional chemotherapy and radiation, but they are responsive in most cases to tyrosine kinase inhibitors. Let's talk about tyrosine kinase inhibitors. We can use these with a neoadjuvant goal in mind, with the idea of reducing the tumor preoperatively. We can use them with an adjuvant goal in mind in order to maintain remission after surgery, or we can use them to improve survival in advanced cases of advanced disease. This was quite an important study published in Lancet in 2004 that compared imatinib, a tyrosine kinase, or the main tyrosine kinase inhibitor, to a doxorubicin-based chemotherapy, and we can see that imatinib dramatically improved survival. So treatment with imatinib is guided by mutation analysis, which is why it's important that we have genetic testing before we begin therapy. So most GISTs will have a mutation in exon 11. This means, and in these cases, most patients respond to imatinib. However, other mutations may not be so responsive, such as exon 9. These patients don't respond as well, and they often require a double dose. So 800 milligrams a day rather than 400. At this stage, I'd like to introduce two studies. This study looked at 56 patients with gastric GISTs above 10 centimeters and gave them 400 milligrams of imatinib daily for 6 to 9 months preoperatively. And as we can see here, well, the objective response rate of these tumors was 62%, and this beautiful waterfall plot shows how the tumors reduced in size under imatinib therapy. What's also important is that in this study, 96% of patients were completely resected, had an R0 resection. And that within these resections, 84% of cases, half of the stomach was preserved. The overall survival and progression-free survival was also excellent. Then this study from the Scandinavian Sarcoma Group on adjuvant therapy that compares 3 years of adjuvant therapy with imatinib to 1 year of adjuvant therapy with imatinib, and is really the basis of why after surgery we give 3 years of imatinib therapy in high-risk patients. Exactly. They were able to show significant improvement in recurrence-free survival and overall survival at 5 years with longer imatinib treatment. So let's summarize what we've learned with this flowchart from the guidelines. In localized GISTs, the goal is surgery. If R0 surgery is possible without major morbidity, we proceed directly to surgery. The specimen then goes to pathology, is analyzed, and we can identify high-risk GISTs. These are, again, high mitosis rate, big tumor, localized outside of the stomach, and certain genotypes. Equally, if there was an intraoperative tumor rupture or R1 resection, this would also be a high-risk GIST, and the patient should receive 3 years of adjuvant imatinib. If R0 surgery isn't possible, either because the tumor is too large or morbidity would be too high, then we should biopsy that tumor, perform the same genetic analysis, and consider neoadjuvant imatinib. The optimal duration of neoadjuvant imatinib treatment is unclear to date, and the criteria used to assess response are also not easy and relatively complicated. However, it's good to remember if there's no difference between 2 CTs, if there's no further improvement, then we should proceed to surgery if possible. If not possible, then we should follow the next flow chart by our guidelines, by the ESMO guidelines. Looks complicated, can be summarized as if there's a sensitive mutation, tyrosine kinase inhibitors. If the tumor is responsive and surgery becomes possible, proceed to surgery. If the tumor isn't responsive, continue treatment, possibly increase the dose, or switch to another tyrosine kinase inhibitor. On the subject of surveillance, how often should we follow up our patients? Well, nobody really knows, as there is no published data on this subject. We know, however, that recurrence happens within the first 3 to 5 years after surgery in most cases, and the ESMO guidelines suggest a risk-stratified approach, so high-risk tumors should be followed up in shorter intervals for the first 5 years, 3 to 6 months. Then for a total of 14 years, they should be followed up. Low-risk tumors should be followed up for 5 years, every 6 months, and very low-risk tumors do not require surveillance. That takes us to our take-home messages. So GISTs are the most common mesenchymal tumor of the gastrointestinal tract. However, they are rare. They are mostly localized in the stomach, but important to remember is those outside the stomach have a higher risk for a less favorable prognosis. Diagnostics include CT, MRIs, endoscopy, and endoscopic ultrasound. Localized disease, surgery is our primary goal. Tyrosine kinase inhibitor therapy is really important in GISTs, but we should do genetic testing beforehand. And we can use tyrosine kinase inhibitors in a neoadjuvant, adjuvant, or setting, or for unresectable metastatic or recurrent disease. That's the end of my presentation. Thank you very much.
Cynthia, thank you very much for this nice overview, an important topic for everyone because the general surgeon needs to know about that, even if he may see only a couple in his life. And every specialist needs also to know about it because it can happen and sometimes they are not diagnosed preoperatively. The diagnosis is not always easy. Next, this is the first really disease when we have a targeted therapy, when we learn here that genetic can change everything. The survival is very impressive, not in all cases, but in most cases. So then that was really the beginning of trying to understand all the genetic and to target targeted therapy on specific tumors and all the development, and probably will be much further in a few years. Maybe one question here, I don't know who want to answer, either Christian, I don't know, is the role of neoadjuvant treatment. As you show, the guidelines suggest here if this is a R0 resection, they just go for surgery, and then you may do all the tests that are necessary. In some situations, tumor is relatively large, so this is really up to the surgeon to decide whether he wants to go or not. And what's the role of neoadjuvant treatment, since we know here that we have a very effective treatment. And I don't think that the Gleevec has a negative impact on surgery, or minimal, maybe I'm wrong. So what is the attitude here in the presence of one of these tumors that we may think we can resect? Should we give Gleevec before, or we go always for surgery?
Our actual policy here is if we have a resectable GIST, and we would prefer to proceed to surgery right away if it's resectable. If we have signs of involvement of neighboring organs, then we proceed for neoadjuvant treatment. That's basically it. I would like to say something about the surgical management of those tumors. I think the main goal, as you have said, is that we achieve an R0 resection with tumor-free margins. And in contrast to other malignant intestinal disease, we are not forced to perform lymphadenectomy, systematic lymphadenectomy. So, for example, for a gastric GIST, we don't need to perform a D2 lymphadenectomy because those tumors typically do not metastasize to the lymph nodes. This is in contrast to the pediatric population, which is a very rare entity, even much rarer than in the adult population. Those tumors can metastasize to lymph nodes as well, and this is a much more complicated situation. And I also want to refer to the special situation in the esophagus, because in the esophagus it's an extremely rare entity, and there's a large discussion whether to perform proper resection of the esophagus bearing segment of the tumor-bearing segment of the esophagus, or to perform simple enucleation of the esophageal tumor, which allows to maintain the intestinal continuity in most cases. And as those cases are so rare, it's a very difficult decision. But there's the French have done a study within their frigate group, and they could show that enucleation achieves equal oncologic results. So in the esophagus, we have a different attitude. We can perform enucleation of the tumor instead of resection of an esophageal segment with gastric polyp or something. Thank you.
Thank you.